Hi, everyone. Thank you so much for being here today. My name is Jordyn Jensen, and I am the Community Engagement and Communications Manager at the Center for Racial and Disability Justice, which is housed at UCLA's Law School. Really excited to be in conversation with you all today about alternative mental health crisis response and what it looks like to build systems that actually respond to crisis with care rather than criminalization. Our presentation today is titled Key Trends in Alternative Mental Health Crisis Response in the United States. This session builds off findings from a forthcoming collaborative report between the Center for Racial and Disability Justice, Human Rights Watch, and the New York Lawyers for the Public Interest, which examines non-police crisis response nationwide. Through this research, we identified more than 150 alternative crisis response programs across the country and conducted deeper analysis of select models to better understand how non-carceral crisis response is being designed and implemented in practice. I'm joined by my colleague, William, who I will pass it to now to introduce himself before we dive in.
Hello, everybody. Nice to meet you all. My name is William Juhn. I am a senior staff attorney at New York Lawyers for the Public Interest. I am part of NILP's Disability Justice Program. Thank you, Jordyn. Yeah, before we, dive into the specifics, I want to just take a few minutes to set the context for today's discussion. Why this topic matters and what's at stake here. And I want to start by sharing a very tragic story, which clearly shows what the issue is. So one day in March of 2024, in Queens, New York, a 19-year-old named Win Rosario was experiencing a mental health crisis. He needed help, so he called 911 for help. But instead of mental health workers, police officers showed up, and the situation escalated immediately. Win was in the kitchen with scissors, so the officers tasered him. When the tasers did not work, the officers fired at least 4 shots and killed him in front of his mother and brother, who begged them not to. Um, Sadly, there are so many more Win Rosarios out there. We're in a mental health crisis. Nearly 1 in 4 of US adults experience mental health issues. The number goes up for young adults, aged 18 to 25 years, is 33%. And 1 in 3 of US high school students reported their mental health was not good. I'm based in New York City, so I look at New York City data, and it's what really was really shocking was that close to 10% of New York City public high school students have attempted suicide, while 16% have seriously considered it. So we're in trouble. We are in a crisis. And the issue is that as we saw in the case of Win Rosario, police has killed or injured many people experiencing mental health crisis. People with serious mental illness are 11 times more likely to experience police use of force and are 10 times more likely to experience injury. People with mental illnesses are also 16 times more likely to be killed by police. Black people with mental health conditions are particularly vulnerable to violent encounters with police, experiencing deadly force at significantly higher rates. I just want to give you an example of New York City. In New York City, the New York City police officers have killed at least 20 individuals experiencing mental health crises since 2015. And of those 20 individuals, at least 16 of them were people of color. This is not about, blaming police officers. They're simply not mental health workers. They're not trained to handle mental health crises. We cannot and should not expect police officers to solve every problem in our society. That is why we need to change the crisis response system and structure. So, this is the context in which, we're going to present our discussions today. Um, Gonna pass it over to Jordyn.
Thank you, William. I want to now briefly walk through what we'll be covering in the rest of today's session. We'll start with an overview of the national landscape of non-police crisis response programs, and we'll define what we mean by non-police crisis response. We'll walk through our research process and the key trends that emerged from our analysis. We'll also highlight the criteria we use to identify rights-based crisis response models, along with examples from selected programs. And finally, we'll close our session today by discussing some of the major challenges facing these programs and where the field is headed next. So I want to zoom out and situate the broader landscape of non-police crisis response in the United States. What we've seen nationally, particularly since 2020, is a significant expansion of alternative crisis response models. Communities across the country have been developing new approaches to responding to mental health and substance use crises without relying on law enforcement. At the same time, though, there's a great deal of across programs and how they operate in practice. Program structure, staffing, dispatch pathways, and service scope differ widely depending on local infrastructure and investment. And importantly, definitions of what counts as an alternative also varies significantly. What we saw through our initial research for this report is that not every program labeled as an alternative actually removes police from the response. So to ground us, I also want to briefly walk through what non-police crisis response teams typically look like and what we mean by that. These programs are generally made up of unarmed responders that do not involve police, including peers with lived experience, crisis workers, counselors, social workers, clinicians, and/or EMTs. They're usually housed outside of police departments, often within public health agencies, community-based organizations, nonprofits, etc. And under this model, when someone calls for help related to a mental health crisis, a non-police crisis response team is dispatched instead of law enforcement. These teams typically respond to nonviolent situations, and police are not the default responders. So once on responders focus on de-escalation, assessment, crisis stabilization, and work to connect individuals to services, provide immediate support, and offer follow-up care when needed. So the goal of this model is really to ensure that people experiencing a mental health crisis and people experiencing those crises are met with care and support rather than force or criminalization. So given this landscape, we also want to examine why non-police crisis is necessary. One commonly cited reform has been crisis intervention training, or teams, typically referred to as CIT for short. CIT training for police is designed to help officers respond more safely to interactions involving people experiencing a mental health crisis. It aims to reduce harm and improve de-escalation. However, CIT training while it's been widely adopted, research shows mixed results regarding its effectiveness. Studies have found limited evidence that CIT reduces arrests, injuries, or use of force. And importantly, the mere presence of armed, uniformed officers can still escalate distress, regardless of training. We also see persistent reliance on police, even in places where alternatives do exist. In many jurisdictions, police remain the primary or default responders, and alternative programs might operate alongside them rather than replacing them. This reinforces the need for crisis response models that are truly non-police. And I'll pass it to William
continuing on that discussion of why we need non-police responses, one reason is that mental health issue is a health issue, so we need a health response to a public health crisis. So when people, have health emergencies, health professionals like EMTs respond to the scene instead of police because they're trained to do the work. Likewise, when people have mental health emergencies and issues, mental health professionals instead of police should respond to the scene. Um, Another reason is that um, non-police mental health crisis teams are effective. As many of you know, there's a program called Cahoots in Oregon, which has been around for more than 35 years, which dispatches a mental health crisis worker with the medic to respond to a variety of calls, including mental health crisis calls. The team members receive over 500 hours of training, including de-escalation and crisis intervention tactics. Um, they're effective. They receive over 20,000 calls per year, and, and only about 1% of the calls require police backup. In other words, nearly 99% of the calls are resolved by the Cahoots teams without any police intervention. So this shows that non-police teams can provide the necessary support to people experiencing mental health crisis without police intervention. Studies show that non-police mental health crisis teams are also cost effective because they can save costs by reducing reliance on expensive hospital system, emergency system, and criminal justice systems. For example, Cahoots costs about $2 million per year, but it saves taxpayers an average of $8.5 million every year. And further, by reducing the emergency room and ambulance transportation, Kahoot saved roughly $14 million in emergency medical care. In the summer of 2023, New York Lawyers for the Public Interest and Human Rights Watch launched a joint project to explore the question of how different communities across the country respond when someone is experiencing a mental health crisis. We specifically wanted to focus on programs that do not deploy police as initial responders or as automatic co-responders. So, this whole project excluded co-response teams from from the survey, in which police officers are paired with other service providers. Because even when another provider is present, we believe the involvement of police can increase the risk of escalation, violence, and incarceration. So this initial, which we'll call phase one of the research, the landscape survey lasted several months. And as part of this initial research, we identified over 150 non-police response programs nationally. You can just Google, HRW, an LP list, and then you'll be able to find a directory to the list of programs out there. Programs. So location. Most of the programs that we found were concentrated in urban areas, both large and small. For example, Denver, Colorado, with a population of over 700,000, and Fairbanks, Alaska, with a population of just over 30,000. They both implemented non-police crisis teams in early 2000s, early 2020s. California had the largest number of programs with 28 non-police response programs, followed by New York with 15 non-police programs. So in terms of location, we're really seeing, these programs being, piloted in many different all across the country. Operational framework. So the program designs, really vary according to the programs. Local governments, often play a central role. In some cases, we see multiple government agencies collaborate to operate the program. For example, a police department works with fire department to operate a joint program. Police department work with behavioral um, agencies to operate a program in many different forms. So, and in other cases, we see local governments contract with private nonprofit organizations to run the program. And in other cases, we see, nonprofits operate their own independently of local governments, with funding from, local or state governments. So in terms of the operation frameworks, we really see, many different formats, being emerged all throughout the country. Team composition. The composition of the teams, differs depending on the community needs and resources. They may include peers, who have lived experience with mental health disabilities or substance use. We also see clinicians, social workers, EMTs, nurses, counselors, and other crisis prevention specialists. But notably, at least 3 dozen programs of 150 programs studied have formally integrated peers into their teams. So that's we think that's a pretty high, ratio there. Um, uh, and then in terms of operating hours, there are, many programs that operate 24 hours a day, but many are currently limited to specific time windows. Program administrators frequently express interest in expanding the hours, but staffing and funding, are always the issue and major as to expansion of the operating hours. Um, in terms of call triage, the programs respond to, a range of calls involving people experience mental health crises, substance use, or other nonviolent situations that do not require law enforcement. Um, although the programs that, we identified do not automatically correspond with police, they may do so in certain situations, for example, that involve weapons. So we do see, in certain cases where uh, uh, in situations involving weapons, these non-police response teams would uh, call the police, for backup. And most of the programs receive calls through 911 or their own dedicated hotlines. And some have, started integrating with the national 988 suicide and crisis lifeline. In terms of services provided, the programs generally provide a range of services, including on-site assessments, this de-escalation, safety planning, crisis counseling, transportation, referrals to community resources, and follow-ups. The programs, often, respond in person at the site of the crisis, whether it be, individual's home or other community locations. In terms of funding structure, some programs are supported through city or county general funds, while others receive state, federal, or private foundation funding. Many of them, combine multiple public and or private sources because funding is always an issue for a lot of the programs. A few programs, receive public resources from like county-wide sales taxes, approved voters to support their work?
We narrowed the initial landscape of more than 150 programs down to 8 illustrative case examples. These programs were selected because they demonstrate one or more of the non-police rights-based components that we identified. And it's important to note that inclusion here does not mean these programs are perfect models or comprehensive solutions, but rather they offer insight into how non-police crisis response can be designed and implemented in practice. The programs here, which include, and I'll just read this list briefly, but note that in our report, we do dive into what these programs are, what their staffing looks like, and other factors more explicitly. So these programs include Mental Health First in Oakland, California, the Mobile Assistance Community Response of Oakland, MACRO for short, and also in Oakland, California. Cambridge Holistic Emergency Alternative Response Team, or HART, in Cambridge, Massachusetts. Mobile Crisis Response, MCRT, in San Diego County, California. New Orleans Mobile Crisis Intervention Unit, MCIU, in New Orleans. Elm City Compassionate Allies Serving Our Streets, New Haven, Connecticut. Support Team Assisted Response, the STAR program in Denver, Colorado, and then NetCare Access Community Mobile Team, or NetCare for short, in Franklin County, Ohio. So these programs, that we featured span different geographic regions, operational structures, and staffing models, allowing us to examine how rights-based non-police crisis response principles are being applied across various contexts. So one of the 4 criteria, which we mentioned and identified, is the diverse participation of peers, meaning individuals with direct lived experience of mental health crisis, substance use crises, or other intersecting systems. Peers are essential to ensuring crisis response programs remain person-centered, trauma-informed, and culturally responsive, and they help build trust, reduce stigma, and strengthen accountability across program design, frontline response, and oversight. Because peers bring lived experience, they are often uniquely positioned to connect with individuals experiencing a mental health crisis, navigate de-escalation, and ensure responses remain grounded in dignity and self-determination. So 4 of the programs that we highlight within this criteria in our report include the HEART program, Mental Health First, Compass, and NetCare. So HEART is one example of this, which is the Cambridge Holistic Emergency Alternative Response Team based in Cambridge, Massachusetts. HEART operates as a peer-led crisis response model with responders bring experience navigating a mental health crisis and other intersecting systems. This program initially launched a peer support line and has been working to build out a broader non-police crisis response infrastructure. Because of its peer-led structure, lived experience is embedded directly into service delivery, program design, and governance. And the model centers voluntary consent-based crisis support and operates independently from police response. Another example is Mental Health First, which is based in Oakland, California. Mental Health First began its operations in 2020 and is run by the Anti-Police Terror Project, which is a Black-led, multiracial, intergenerational coalition focused on building community-based responses to violence and crisis. The program deploys volunteer staffed 3-person mobile crisis teams. So these teams typically include a nurse or EMT, a mental health or a crisis responder, and a peer. And then Mental Health First operates during designated weekend hours and can be reached through a dedicated phone or text line. People with lived experience are directly and have been directly involved in designing and co-creating the program and continue to hold leadership and decision-making roles. Mental Health First views peers as bringing both issue competency and situational competency, meaning they understand crisis not only, clinically, but through lived and community experience.
So, Compass is located in New Haven, Connecticut. It's a crisis response program developed through a community-driven process launched in 2021. So each team includes a social worker and a peer support specialist. So each response team, includes a peer, with lived mental health or substance use experience, who has undergone a specialized training to become a mental health or addiction specialist. So in addition to this, peer-led approach, the Compass has a community advisory board, which plays a vital role in ensuring oversight and accountability. And this advisory board includes individuals with lived experience, and people from diverse racial and ethnic backgrounds, and formerly incarcerated individuals, so that they can ensure that historically marginalized voices are centered in decision-making process for the program. NetCare is another program that's highlighted in our report as incorporating a lot of good aspects of the peers into the program. So NetCare is based in Franklin County, Ohio. It's a mobile crisis response program launched in 2023, serving Columbus, Ohio, and surrounding areas in Franklin County. Each mobile team consists of a licensed clinician and a certified peer recovery specialist. Um, with lived mental health or substance use experience. These peers play a vital role in supporting individuals during crisis, sharing their own experiences to build trust and connect with the individuals. The peers are trained in motivational interviewing and actively engage clients in conversations about their goals and care decisions. So, the program says, they say the peer is really essential in talking through what the individual wants and what their goals are. And they share their own experiences and offering the perspective from the peers. So in addition to that, NetCare also integrates peers into their follow-up services as well, offering continued engagement for up to 14 days post-crisis to help the individuals in crisis stabilize and connect with essential resources. So this is just, example of how our report is designed. So what we do as part of the report is that maybe you might remember the 12 categories that components of rights-based response models that Jordyn described earlier. What we try to do is for each component, we try to highlight the programs that do a good job in that specific category, and and how each program exemplifies that specific component, and we try to illustrate that point. So that's what we do.
So, while the expansion of non-police crisis response programs is promising, our research also identified several structural challenges facing these models. So, first, funding instability remains one of the most significant barriers. Many programs rely on short-term grants, pilot funding, or patchwork public health dollars rather than sustained investment from, their cities or states. This makes long-term planning, staffing, and service expansion extremely difficult. Second, we see capacity limitations across many programs. This can include limited operating hours, staffing shortages, or restricted geographic coverage. As a result, some programs are not yet able to provide 24/7 response or citywide service. Third, dispatch, infrastructure remains a major challenge. In most jurisdictions, police departments still control 911 systems, and so this means access to non-police crisis response is often mediated through law enforcement, and call diversion pathways remain limited or inconsistent. We also see the continued dominance of co-responder models. So in many places, clinicians are deployed alongside police rather than in place of them, meaning alternatives operate in parallel rather than as true replacements. Beyond program infrastructure, there are also broader political and policy challenges that we're currently facing. This includes expansion of involuntary commitment laws, reinvestment in institutional responses, and public safety framings of mental health crisis that can undermine support for community-based alternatives. And finally, workforce development remains an ongoing issue, particularly in building and sustaining peer responder pipelines, ensuring things like equitable pay and providing adequate training and support. So taken together, these challenges, although this list is not, expansive, and there's several additional challenges that these programs face, they show that while non-police crisis response programs have grown in recent years, it remains unevenly resourced and structurally constrained across much of the country.
And with that, I'm gonna just briefly talk about in closing the next steps. So our report is coming out on March 30th. So please be on the lookout for the report. And we're also planning to have a virtual panel discussion relating to the report, and we're also planning to invite some of the program staff of the programs that are featured in the report sometime in April. So please be on the lookout for that panel discussion event as well. What we're also doing here at NILPI is we are only updating our initial survey that we did, where we identified 150 programs, where we have a researcher that's actually working on updating that list. Because that research was done in 2023, and we know that there's so many new programs that emerged, since then. So we are finding many programs, that have emerged since then, and we are planning to finish that update by this summer. So we're in the meantime, please Google, HRW NILPA report. You can, see the list of the programs, and, you can, have a deeper dive into the programs that way. But we're also planning to update lists by the summer, and we're gonna post that link up on the website, our website as well. With that, thank you so much for listening to our presentation today. We look forward to your questions and discussing the issues further with all of you. Thank you so much.